You're welcome to webinar number 11 in our bi-weekly Wednesday webinar series. For those who are first-timers, my name is Dr. David Rawson, founder and president of the Canadian Academy of Clinical Sleep Disorders, CACSDD for short. Tonight, it's our pleasure to share with you a Canadian in the name of Dr. Sharon Morong. Sharon is a physician and an otolaryngology head and neck surgeon, subspecializing in sleep medicine and sleep diagnostics. She's also a lecturer in the Department of Otolaryngology, head and neck surgery at the University of Toronto. During her career, she has received numerous awards, has published multiple peer-reviewed articles and book chapters on sleep medicine and sleep surgery, and has spoken on national and international platforms about drug-induced sleep endoscopy. She's now the director of the Sleep Endoscopy Centre for Snoring and Sleep Apnea in Canada. Tonight's topic, presented by Dr. Morong, is drug-induced sleep endoscopy, or DICE, D-I-C-E, the missing link in sleep medicine collaboration. Without any further ado, welcome to our academy, Dr. Morong.
Okay, so good evening, everyone. Firstly, David, thank you so much for giving me this opportunity to speak with everyone today. The goal of this talk is to speak to you about drug-induced sleep endoscopy, or sleep endoscopy for short, and its usefulness in all spheres of sleep medicine. So for those of you who may have known me from before, you know that I'm an otolaryngology head and neck surgeon affiliated with the Mackenzie Health Hospital and the University of Toronto. But what a lot of people don't know is that I'm also a sleep medicine and sleep diagnostics physician currently working at these locations. So my journey began here in Toronto for medical school residency, but then I went on to do my fellowship in Amsterdam to train in sleep medicine, sleep endoscopy, and sleep surgery. And we all know Amsterdam for their windmills, their beautiful tulips, their breathtaking canals. But Amsterdam and Europe are very well renowned when it comes to their leadership and innovation for patients who have snoring and sleep apnea. So I was super excited to learn as much as I could from them. And yes, their medicine, research, surgery, excellent. But what really resonated the most with me was their approach to patients with sleep apnea. So let me explain that a little bit more. Here in North America, when we think about patients who snore or who have sleep apnea, we typically think of three options that are offered to the patient. One is CPAP, and that's typically offered by the sleep physician and is very effective for most patients, but we all know that compliance is a huge concern. The other modality that's offered is surgery, be it soft tissue, upper airway surgery, or orthognathic maxillofacial surgery, and that too can be very effective, but it has to be for the right patient, and there are associated risks with it. We also have oral appliance therapy, and oral appliance therapy, can be very effective as well, but it is a wearable device. It's not for everyone. So ultimately, all three options here have their pros and cons, and typically these options are all given by three different groups. CPAP is typically offered by sleep physicians, surgery by surgeons, and the oral appliance by dental professionals. The problem is that very rarely do you find these three groups interacting with each other to find treatments that can work for the patient. We all seem to work in our own silos. And at the end of the day, it leaves a patient oftentimes very confused or frustrated with the whole process. So in Amsterdam, it's totally different. You have these three groups working together to figure out the best treatment or treatments for a particular individual. So it's a tailored, patient-centered approach versus a one-size-fits-all. And, it's a very healthy collaboration. And the part of the reason why the collaboration is there is because of a technique called sleep endoscopy. Now, sleep endoscopy is a technique that's used to identify the sites, anatomic sites of snoring or sleep apnea, and it can help to guide the decision-making process when it comes to treatment. So one could argue that we have lots of different techniques for assessing the airway, And that's true. We don't have a gold standard for assessing the airway when it comes to sleep apnea. So let's talk about a few of these techniques. So here we have a cone beam CT. We all know that cone beam CT has been shown to be a very good predictive tool for identifying patients who are at risk for sleep apnea, but it is done in a patient who's awake. It's a static assessment. And there is the issue of radiation exposure, albeit the levels are low, it's still there. Then we have sleep MRI. This is a very high resolution dynamic way of examining the upper airway, but it's very expensive. And we have very limited to no access to this type of technology. In the ENT clinic, we have a maneuver called the Mules Maneuver. So the Mules Maneuver is pretty much where the airway is visualized endoscopically in the patient. And we ask the patient to inhale, keeping their mouth closed and their nostrils plugged. So we're trying to induce collapse of the airway. And it is a dynamic assessment, but again, the patient is awake. And we find that the findings are typically very non-specific. So let's talk about sleep endoscopy. So sleep endoscopy was first reported back in the 1990s in the UK, and it was reported as a fiber optic examination of the upper airway to identify the anatomic sites of obstruction for patients who have snoring or sleep apnea under sedation. So you're doing this under sedation while the patient is spontaneously ventilating. So here we have a diagram, and I am just going to make sure you can see my mouse so I can show you what's happening here. So can everyone see my mouse? I hope so. Here we have an endoscope, and the endoscope is being inserted into the nose. And as it reaches the back of the nose, it curves down so that you get a bird's eye view of the upper airway. And from this vantage point, you can inspect the anatomic sites. So the first site that we look at is the velum. The velum comprises the soft palate. Second site, we look at the base of the tongue, the lateral walls, the tonsils, and then we look at the epiglottis. So when we look at these sites, we ask ourselves three questions. One, is there an obstruction? Two, what type of obstruction are we looking at? And three, how severe is the obstruction? When we ask ourselves these questions, we grade the airway using a specific classification system. Okay, and this system is called the VOTE classification system. There are lots of other classification systems, but this one is the most common, most popularly used. So VOTE stands for V, velum, O, oropharynx, T, tongue, and E, epiglottis. So once we've asked ourselves the three questions at each of these sites, then we can score what we've seen. So at each site, we score a level of 0 if there's no collapse or obstruction, level of 1 if there's partial collapse or obstruction, and a level of 2 if there's complete collapse or obstruction. This classification was developed by Dr. Eric Kazarian at the University of Southern California, and also my fellowship supervisor, Dr. Nico de Vries from Amsterdam. So who's eligible for sleep endoscopy? Typically, patients have to have a BMI of 35 or less. They need to be either patients who have sleep apnea, or if they don't have sleep apnea, they're primary snorers. They have to have an ASA level of 2 or less, which means that they're either healthy, or if they do have other comorbidities, they're controlled. And all of these patients need to have sleep studies done. So for me, with my patients, I offer my patients different options. I give them the option of having an in-lab sleep study done. So this is a level 1 sleep study where we assess the sleep parameters in addition to snoring, sleep apnea, and this is all done under video surveillance. For patients who are not comfortable having a study done in lab, we do offer 2 types of home studies. One is a level 2 study, which is pretty much the same as an in-lab, in that we are assessing the sleep parameters as well, but there's no video involved for that one. We do offer the level 3, which is a standard home device kit, where you are assessing snoring, sleep apnea, but there's no sleep that's being assessed. So sleep endoscopy typically can occur in an operating room or an endoscopy suite. we have a team that's there. The team should comprise an anesthesiologist or a physician who can perform the sedation, a nurse that needs to be present, and the surgeon who's actually performing the procedure. The environment, we try to keep it where the lights are dim and we have very minimal noise. So what sedative agents are used? These are the most common. We have propofol, we have dexmedetomidine, midazolam, or a combination of midazolam and propofol. For my patients, I use propofol, and the reason why I use it is that it has a very rapid onset of action. The half-life is short, and you have rapid recovery. So I'm able to get my patients to that level where they're snoring, there's obstruction that's there, and get them out of it quickly. There are minimal side effects using propofol, low incidence of post-op nausea, vomiting, or headaches, and the effect on respiratory depression is much lower than what you would see with benzodiazepines. You will hear about the cardiovascular effects of propofol, such as a decrease in blood pressure or a decreased cardiac output, but this typically occurs at very high doses above the levels that we use for sleep endoscopy. So how do we administer the sedation? Again, there are lots of different options. One is a target-controlled infusion. So that's basically a computer-controlled system that takes into consideration the patient's body weight and the patient's age in determining the amount and speed of the propofol infusion. You have other techniques as well. We have the bolus technique, and we also have a technique using continuous infusion. So how do we monitor the level at which a patient is sedated? There are two ways of doing it right now. One is the clinical route, and the other one is the use of a bispectral index monitoring. Now, clinical is usually the most common because we have the most access to this. There's no equipment involved. What we typically do to determine if we have a patient at the right level is, firstly, we look to see, is the patient snoring? Are there signs of obstruction? Does the patient respond to verbal commands? They should not respond to verbal commands. Their eyelash reflex should be inhibited, but their pain stimulus should not. The other type of monitoring is the bispectral index monitoring. This is an EEG analysis that's done where it's scored from level 0 to 100. Level 0 meaning that there's no brain activity. Level 100 means that the patient is fully awake. Studies have shown that BIS levels for natural sleep usually fall within the range of 49 to 61. So in doing sleep endoscopy, that's the range that you want to be at. It's a very objective measure, but unfortunately, we have limited access to this type of monitoring. So hopefully it's something that will be more available and accessible in the future. So let's take a look at a few videos here as examples of the obstruction, but the first thing I'm going to show you is an example of a patient who has no obstruction. So here the scope is curved down. You can see bird's eye view of the airway. Here's the front, here's the back, right? The palate is nicely open. Lateral walls, we have our tonsils here, tongue base, the epiglottis, everything is open. You can see right down to the vocal cords. So this is what no obstruction should look like. Now let's look at the level of the palate. Okay, so the first type of obstruction here is called an anterior-posterior palate obstruction. There's no sound here. So here's the front of the palate. Here's the back wall of the airway. The vibrations indicate that there's snoring, and you can see that the obstruction is an anterior-posterior one. It's just going from front to back. Okay. As the scope goes further down, you can see, however, that everything below looks open, right? At the tongue base, the epiglottis. So this patient has an isolated anterior-posterior palate obstruction. So we're going to stay at the level of the palate, but now you're going to see a different type of obstruction. This is called a concentric palate obstruction. You can see the palate is closing in almost like a sphincter, okay? But everything below that, again, was open. So this is an example of, obstruction at the same level, but we're looking at two totally different types of obstruction that can be seen. And that has implications for management. So next, moving down to the tongue base. You see here that at the level of the palate is nice and open. But then as you go further down, you can see here the tongue base is just pushing on that epiglottis, obstructing the airway. Typically in patients like this is where we would do a jaw thrust maneuver to simulate an oral appliance to see if it would actually open up the airway. So we do that for obstructions noted at the tongue base as well as the epiglottis. Okay, so now we're at the level of the epiglottis. Going to look at a lateral epiglottis obstruction here. So again, we are going down, palate is open, the tongue base isn't obstructing, but you look at the epiglottis here, and you can see the sides of the epiglottis is curling in. It's almost like a C shape. And you can see the vibrations representing snoring for the patient. So this is called a lateral. And now we're going to do a jaw thrust maneuver here to see if things open up. And it does. Here we can see the vocal cords, the arytenoids, and you'll see here the palate is open as well. So this is a patient who would do well with an oral appliance. So now we're staying at the level of the epiglottis, but now you're going to see a different type of obstruction. This is the anterior-posterior epiglottic obstruction. So you'll see here the epiglottis is almost suctioning back onto the wall, the posterior wall of the airway. And that's what we call a trapdoor phenomenon that is happening with this patient. So again, same level, but you can have totally different types of obstruction occurring. So now that we've looked at, different types of obstruction, let's take a look at how sleep endoscopy can be applied to different practices within sleep medicine. So first, looking at oral appliance therapy. There was a retrospective review that was done that looked at patients who had a sleep endoscopy performed. And they found that in those patients that had improvement with the jaw thrust maneuver, not only at the level of the tongue base, but also at the level of the palate, did much better with their oral appliance therapy compared to patients who did not have sleep endoscopy done before getting their oral appliance. So if you look at this review, there were 40 patients that were reviewed, and they were split into two groups. So we have our sleep endoscopy or DISE, Drug Induced Sleep Endoscopy group. These patients had sleep endoscopy done, and based on those findings, obtained an oral appliance therapy. Then we have our no DISE or no sleep endoscopy group here, and these patients obtained their oral appliance without having sleep endoscopy prior to this. Between these two groups, there were no significant differences seen in demographics or their AHI or oxygen minimum saturation or their ESS scores. So looking at treatment success, and treatment success here was defined as AHI less than 20 with at least a 50% reduction in baseline. So for the sleep endoscopy group, there was a 75% success rate seen compared to the no sleep endoscopy group where there was a 50% success rate. Looking closer at this group, they found that 45% of patients in the sleep endoscopy group had an AHI, were able to obtain an AHI less than 5 with their oral appliance compared to 15% of patients in the no sleep endoscopy group. So the highlights of this is that sleep endoscopy can be a useful tool for predicting oral appliance therapy success. So looking at another study here, it was a case series, and here they found that sleep endoscopy was able to identify residual locations of collapse in patients who did not have a complete response to oral appliance therapy. So in this series, there were 35 patients with sleep apnea, and they defined incomplete response as patients who had their oral appliance, but they had a persistent AHI above 15, or their AHI was above 5 and they still had subjective symptoms. So of this group, what they found was that in patients who did have an incomplete response, the majority of them had residual collapse at the level of the palate. So 42.9% of these patients had residual palatal collapse. The other 20% of patients had residual collapse at the level of the epiglottis, right? Interestingly, the remainder of patients had no collapse. They don't really speak much about this group, but I think that's a very interesting group that should be looked into further. But the highlight of this study is that sleep endoscopy can be very helpful, right, in determining what to do next, right? What is the management for your patients who don't respond fully to oral appliance therapy? Sleep endoscopy can help guide you to that next step. So let's look at positional therapy. So the highlights of positional therapy is that what they've really found with sleep endoscopy is that patients who seem to have lateral wall collapse don't do very well with positional therapy, whereas patients who have a reduction in the collapse at the level of the tongue base or the level of the epiglottis when they're turned on their side seem to do well with positional therapy. Let's look at upper airway surgery. So Koutsouralakis et al., they had a study where they looked at sleep endoscopy in patients to determine outcomes for surgery. And what they found was that patients with anterior-posterior collapse at the level of the palate tended to do better when they had surgery done, whereas patients who had that complete concentric collapse that you saw in the video before, or complete tongue-based collapse, did not do as well with surgery. This was another study that was done where with sleep endoscopy, they showed that patients who had lateral wall collapse as well didn't do very well with surgery either. So there's been a more recent and exciting branch of upper airway surgery, which has been upper airway stimulation using the Inspire device. And the mechanism by which this works is that you have stimulation of the hypoglossal nerve branch, which causes tongue protrusion and leads to opening of the airway. So here you can see we have three components here. We have our implanted impulse generator, a sensing lead, and you have the hypoglossal nerve stimulation lead. So when a patient inspires, the sensing lead detects that inspiration. And once it detects that inspiration, the impulse generator then sends a signal up to the hypoglossal nerve stimulation lead to cause the tongue to protrude, open up the airway. So studies have been done looking at sleep endoscopy and upper airway stimulation. And what they found was that upper airway stimulation did not seem to reduce the severity of OSA or sleep apnea in patients who were shown to have concentric collapse of the palate. And these findings were so significant that the FDA actually made regulations to say that any patient that had concentric collapse needs to be excluded from being eligible for this device. So now you will see across institutions as part of their screening criteria, DICE has to be a part of it, and patients need to show that they have anterior-posterior collapse in order to be eligible for the device. So let's take a look at maxillomandibular advancement surgery. So in this study, what the authors found was that patients who seem to have lateral wall collapse on sleep endoscopy actually show the largest reductions in AHI after having MMA surgery. And what they concluded was that not only should DICE or sleep endoscopy be a part of the screening process for MMA surgery, but patients who show that they have lateral wall collapse, amongst other factors, of course, should definitely be included in the selection criteria for MMA surgery. In this study, they wanted to look at upper airway collapse patterns. They noted that in general, when you look at the literature, it seems that patients who have complete concentric collapse of the palate don't do very well with any treatment modality, be it upper airway surgery, upper airway stimulation, or even oral appliances. So they wanted to perform a study to see if this finding would be a negative predictor for MMA surgery as well. And what they found was that it's not. Concentric collapse is not a limiting factor for having a successful outcome after MMA surgery. What they did find, however, was that patients who had epiglottic collapse on sleep endoscopy before having MMA surgery still had that epiglottic collapse after MMA surgery as well. So the take-home message here, and I put part 1 because there are a few, is that for all treatment modalities, sleep endoscopy can not only help you to determine who will have a successful outcome, but it can also help you to determine who will not have a successful outcome. So you may ask, well, what about CPAP and sleep endoscopy? Does it have any role when it comes to CPAP? And I will get to that in the case presentations. So sleep endoscopy is safe. You have a dynamic, direct visualization of the anatomic sites for snoring or sleep apnea, and you get a 3D assessment of the airway. Studies have shown that it is valid. Various studies have looked at patients who do not have snoring or sleep apnea, and when they have sleep endoscopy done, there's no snoring that's seen. However, patients who do have sleep apnea do show elements of snoring or obstruction on sleep endoscopy. It has also been shown to be reliable. So there have been studies looking at inter-rater reliability and test-retest reliability, and it has been reported to be moderate to substantial. In terms of the risks of sleep endoscopy, patients may have some pain when you're infusing the anesthetic agent. Allergic reactions can occur, but it's very rare. And you do have that risk of oversedation, right, leading to airway compromise. And the way to prevent this is to titrate to the lowest level of sedation that's necessary, have a face mask ready to administer positive airway pressure if it's needed. Based on the literature and based on my experience, there have been no severe side effects or emergency situations, no intubations or tracheostomy. So this is a fairly safe procedure. So what are the limitations of sleep endoscopy? So, a big limitation is that there's a lack of standardization across institutions and seen globally when it comes to what sedation is used, the technique, the level of monitoring, how monitoring occurs, even the classification schemes, they all vary. So that's something that needs to be standardized so that we can improve upon the reliability that we see. The other limitation is that right now we don't have the ability to actually quantify our findings. So I think these are areas that are constantly evolving and are under research at this present time. And hopefully in the future there will be some changes or improvements here. So the critiques of sleep endoscopy. Main critique is that sleep endoscopy is not a true reflection of normal physiologic sleep because you are giving a patient sedation. And I say, yes, that is true. It is not a normal physiologic sleep. There was a study done by Robello et al. Where they took patients who had sleep apnea and pretty much they would give the patient propofol. So they took each patient and then they would perform polysomnography on the patient with propofol or without propofol for about 120 minutes. And they did this to be able to compare sleep patterns, respiratory patterns, and their AHI with or without propofol. And what they found was that, yes, sleep architecture is altered with propofol, but the respiratory patterns and the AHI did not significantly differ whether the patient had propofol on board or whether they were dealing with natural sleep. The other critique is that we're not able to determine what level of sedation we're at, and that potentially can confound the effects of our results. Now, having the bispectral index monitoring, that's an objective measure, and that's a way to counter this critique. Unfortunately, it's not very accessible at this point. So the emphasis really has to be that not only do you need to have a physician who is experienced with performing the procedure, you need to have a physician who's experienced with giving the sedation for this type of procedure as well. So who are the patients that I see? So typically the patients that I see are patients who've just received a diagnosis of sleep apnea and they're wondering what are their treatment options. Patients who've tried CPAP or refuse to try it and want to know their options as well. Patients who are interested in an oral appliance, but they're not sure if it's going to work. Also patients who have incomplete response to other treatment modalities, be it oral appliance therapy or surgery, they are coming for sleep endoscopy. More recently, I've had some patients coming for as part of a preoperative assessment to help guide the selection for MMA surgery as well. So let's take a look at a few case presentations here. Okay, so first case, we have a 33-year-old male. He was diagnosed with moderate sleep apnea, BMI of 30. He's otherwise healthy, but he was experiencing daytime fatigue and not tolerating CPAP. And his question was pretty much, would an oral appliance work? So on physical examination, he did have a septal deviation. His tonsils were fairly small. Uvula, there was no enlargement per se, and with the tongue, no enlargement or scalloping or vaulting was seen. The chin, there was some mild retrognathia, but there was no obvious anatomic abnormality just based on the clinical exam. So this is an edited version of his video. So here you can see the septal deviation. I'm going through the right nasal passage here. So I'm going all the way to the back of the nose. And then I curl down, and you can see already that the palate is somewhat obstructed, right? So I'm going to move the scope further down. And when I reach the level of the tongue base and the epiglottis, there's complete collapse happening. There's the tongue base, there's the epiglottis, full closure and collapse happening. So now I'm going to do a modified jaw thrust maneuver to see if it makes a difference. And here you can see his arytenoids, his vocal cords are present. And you'll see a snapshot where I look at everything. I look at the level of the palate. There's no obstruction here, and there's no obstruction here at the level of the tongue base or the epiglottis. So I know that this patient should do well with oral appliance therapy. So he was counseled as such, and he obtained his oral appliance. So prior to treatment, his AHI was 20.1 per hour. He had poor sleep, daytime fatigue, but after he obtained his oral appliance, his AHI went down to 1.2 per hour. He had restful sleep, good energy levels. So this patient just needed one treatment modality. But the beauty of a collaboration is that everyone understands that while you do have one patient, or some patients that need one treatment, there are other patients that may need more than one treatment to achieve success. So here are two cases to illustrate that. So this case, we have a 57-year-old male. He was diagnosed with moderate sleep apnea, and he was a loud snorer. His BMI was 30. He had hypertension, diabetes, but he was well controlled. He had obtained an oral appliance, worked well. His AHI went down to 6 per hour, but he had persistent snoring that was affecting his relationship at home. So on physical exam, there were no significant abnormalities seen. So let's take a look at his video. So this video is edited for the purposes of time, and it's edited to focus in on the palate and the lateral wall to show you what happens here. Okay, so first you'll see concentric with snoring, concentric collapse at the level of the palate with lateral wall collapse as well. Okay.
Jaw thrust on.
Now we do a jaw thrust. And you're going to see that the configuration or the shape of the configuration changes. So now his palate has changed to an antero-posterior obstruction. And he still has snoring. So jaw thrust is going to come off. And he goes back to having that concentric collapse. So for this patient, the recommendation here was a combination treatment, right? With the oral appliance, it's not shown here, but his airway opened up really well at the level of the tongue base, the epiglottis. Makes sense. That's why his AHI went down and improved, but he had persistent snoring, and you can see why, because at the level of the palate, there was still obstruction there. The key thing there was that it changed from concentric to antero-posterior obstruction, which was good news for this patient, because we know that antero-posterior collapse is amenable to surgery. So that's what we discussed. And he did not want any surgery which required general anesthesia. So he decided that he would like to have a radiofrequency palate procedure. Now, this procedure is an outpatient procedure. It takes about 20 to 30 minutes, and it's done every 6 weeks for about 3 or 4 sessions, where the patient is given local anesthesia, and then you have radiofrequency heat applied submucosally to different points here on the palate to cause stiffening, scarring, and hopefully to stop the vibrations that would cause snoring. Now, I counsel patients with regards to this procedure because this is pretty much for simple snorers, right? You're pushing it for even mild apneic patients. The only reason that we came to a decision to have a treatment plan with this procedure is because he planned to continue using his oral device. So I know that with the oral device, he's doing well. We just need to deal with the snoring. So we proceeded with having the radiofrequency pallet done. And for him, his snoring did decrease. It was not eliminated, but it did improve. It improved to the point where his partner was no longer sleeping in a separate room, so success was obtained. So if we look at another case here, case 3, we have a 60-year-old male. He had severe sleep apnea, and he had these gasping episodes that he would have at night that would wake him up. His BMI is 29.1, past medical history of hypertension, a history of an MI, reflux. He had tried an oral appliance, and it worked in that he no longer had those gasping episodes, but he still had the snoring that he was concerned about. He was not interested in surgery, so he decided that he would try CPAP. Unfortunately, with CPAP, even at high pressures, in terms of his AHI, there was still suboptimal response. And what was more distressing for him was that those sudden gasping episodes seemed to actually get worse. So he'd wake up, feel tachycardic, and he was very distressed by this. So we did sleep endoscopy on him, and here is his video. So here you'll see he has an anterior posterior obstruction at the level of the palate. As we go further down, take a look at his epiglottis, and you'll see that he's having this, what we call trapdoor. It's being suctioned onto the back wall of his airway.
Okay, jaw thrust down.
So now we're going to do a jaw thrust. Now, when we do the jaw thrust, I'm looking at the epiglottis to see, have we improved it? It has improved. We no longer see that trapdoor effect. So it does work. An oral appliance should work. And it does. But when you look at the level of the palate, there's still obstruction there. And that's why he's still having snoring. So this patient was not interested in any surgical procedure, and he was happy using CPAP as well. So we came up with a plan to do combined therapy for him, have the dental device along with his CPAP machine, and he did very well. So prior to any treatment, he had CPAP pressures of 14 to 15, which were high pressures. His AHI was still at 21.4, and he had those violent gasping episodes that were really causing distress. But, combining the dental device with his CPAP, we were able to get his pressures down to 7. His AHI went down to 3.3, and he was now having restful sleep. So these examples are to show that sleep endoscopy can be very useful when guiding, making decisions with regards to treatment. But a question I often get asked is, what about my nose? Can fixing my nose cure my snoring or sleep apnea? So we know from the literature that nasal correction or nasal surgery can improve the quality of a patient's sleep, and it can improve their energy levels, improving their daytime sleepiness. We also know that patients who are using CPAP but are experiencing discomfort can have nasal surgery done to help relieve some of that discomfort and even reduce the pressures that they need for CPAP. But can nasal surgery improve the AHI? So when you look at the literature, it's split. So you have studies that have been done, reviews that have been done that conclude that nasal surgery does not improve the AHI in patients. But more recent studies and reviews have said that, yes, nasal surgery can improve the AHI in patients. So what do we do with this information? We know that from this, there are some patients who do well with nasal surgery for their AHI, and there are some patients who don't. So the question you have to ask is, are all AHIs made equally? So to try to answer this question, we have to go back to definitions. So AHI, or the apnea-hypopnea index, is defined as the number of apneas or hypopneas that are recorded during a study per hour of sleep. An apnea is a reduction of airflow by at least 90% for about 10 seconds or more. And hypopneas, there are different criteria. I placed some here. It can be a reduction of airflow by 30% for 10 seconds with a 3% oxygen desaturation or an arousal, or you have a reduction of airflow by 50% for about 10 seconds with a 4% oxygen desaturation. The take-home point here is that the definition of an AHI is a heterogeneous one and can differ from patient to patient. So if we look at two patients who've been diagnosed with moderate sleep apnea, they have an AHI of 17 per hour. And we take a closer look at their sleep study, we look at their trend graphs, and you realize that in patient A, they have predominantly hypopneas with very little apneas. Then you look at patient B, you can see that they have predominantly apneas with very little hypopneas. And I'm not getting into it for this talk, but we do have to acknowledge that there are patients who have lots of arousals, which is a factor here as well too. So it's not unreasonable to think that although multiple patients may have the same AHI or be classified in the same severity group, that they all have completely different combinations of respiratory events that lead to the same diagnosis. So therefore, they may have completely different outcomes to the same intervention that's given. So if we go back to the role of nasal correction for snoring and sleep apnea, looking at this study here, they showed that they looked at the impact of nasal resistance when it comes to the distribution of apneas and hypopneas in obstructive sleep apnea. And they found that patients who have a high nasal resistance were more likely, 3 times more likely to be specific, to have a greater number of hypopneas relative to apneas. And that these patients were more likely to have mild to moderate sleep apnea. Now, these findings are important because it means that there are a subgroup of patients, endotype of patients that can respond well to nasal correction. And responding well does not only mean improvement in breathing or improvement in their sleep quality or daytime fatigue. It can potentially mean that you can improve their AHI as well. So does nasal resistance have an impact on oral appliance treatment? Zhang et al., they looked to answer this question. They had 38 patients with sleep apnea who underwent a sleep study with an oral appliance with a mean AHI of 29 per hour. And they defined responders to oral appliance as patients who had a 50% or more reduction in their AHI. And they measured nasal resistance with a rhinometry. What they found was that responders to oral appliance treatment had significantly lower nasal resistance than patients who did not respond to oral appliance therapy or treatment. And they also found that nasal resistance seemed to increase significantly in the supine position for patients who didn't respond well to oral appliance therapy, whereas patients who did respond overall well to oral appliances did not have that significant difference. Whether they were sitting up or lying down, their nasal resistance didn't change much. Now, for me as an otolaryngologist, that finding is of great interest because in clinic, when I have a patient who voices concern about nasal congestion, that is worse at night. It's worse when they're lying down. It's worse on the right side when they turn to their right. It's worse on the left side when they turn to their left. For us, that's a signal that the tissues in their nose, their turbinates, are likely a big contributor to their nasal congestion. And that's something that can be treated, which I will speak to shortly. But overall in this study, they showed that BMI is not the only important predictor for oral appliance treatment, but nasal resistance is as well. So the take-home message here is that for a patient who has sleep apnea, who is not responding completely to oral appliance therapy, revisit the history when it comes to their nasal congestion or nasal obstruction, review their sleep study, look at the trend graphs to see what is the distribution of hypopneas or apneas. Do they have more hypopneas, less hypopneas? And based on this, you can counsel your patient to say, you have a patient, for example, who has mild or moderate sleep apnea. they are not responding fully to oral appliance therapy. They do have that nasal congestion that's there. And you can let them know that, you looked at the sleep study, you can see that they have more hypopneas than apneas. So it is possible that nasal correction may actually be able to improve their AHI along with all of the subjective symptoms that they may be having as well. And that patient should be referred on to an otolaryngologist for assessment. So when I see patients that have a history of persistent snoring or sleep apnea despite any treatment modality, be it surgery or oral appliance therapy, and they also have nasal congestion, that they've tried multiple sprays for lengthy periods of time and it has not helped, I do a physical exam and I see that their turbinates are enlarged. There's no severe septal deviation, there's no sinus disease. The management that I discuss with them is something called therapeutic sleep endoscopy. So therapeutic sleep endoscopy is where you have sleep endoscopy being performed in addition to another procedure that's providing some form of treatment for the patient. In this case, the procedure that's being performed is a radiofrequency of the nasal turbinate. So you're applying radiofrequency energy to those turbinates to shrink, contract, reduce the turbinates to open up that nasal passageway, reduce that nasal resistance. So here's just a picture showing a patient, not my patient, but a patient. It's an endoscopic view here of the left nostril. And here we have the septum, and here's the turbinate. And you can see this turbinate is quite swollen. It's obstructing the whole passageway. And this picture shows the patient after having radiofrequency. Now, this shrinkage and contraction doesn't happen right away. Some of it will, but most of it takes time. So over the next 3 or 4 weeks, you have this general contraction that can happen that can open up the airway for patients to hopefully provide some relief. So the final take-home messages. Identifying the site of airway obstruction in sleep apnea is critical to be able to successfully treat the majority of our patients with sleep apnea. Sleep endoscopy is a great tool because it's dynamic, it's structure-based, and is being performed in real time. It's important to remember that one therapy, no matter how good that therapy is, just may not be enough for that patient. They may need combined treatment for successful management. Throughout everything, don't forget the nose. And above all, collaboration. Collaboration is key. It's such an essential component to all of us, just making one step further to providing precise, targeted care, effective care for our patients. Thank you.